Here we are in Season 4, Episode 4. We're going to talk about a systematic approach to treating cracks. And so, in the world of dentistry, cracks have been recognized for decades, maybe even 100 years. But the idea is that the treatment of cracks went to a plateau where there was some success with full coverage of teeth that had a cracked tooth syndrome. And that was first talked about in the 1960s by Cameron out of USC. And other investigators applied this and had some success. Some fairly long-term studies, 3 or 4 years, showed some success. But when I was taught that system in 1970s for cracked tooth diagnosis and treatment, I went into private practice. First, I was in the Navy for 3 years and then into private practice. And full coverage restorations were the only thing that really was talked about. And so that's what I did. If I had a tooth that had consistent pain on biting, I really didn't focus in on cold sensitivity. I didn't really understand that source of dental pain at that time. But if a patient had a consistent pain on biting, then we would make the diagnosis cracked tooth syndrome. And then I would treat that pathology with full coverage. There usually was some improvement, but quite often, and I'm not getting specific numbers, I don't have a collection of data, but in my mind, at least 20% of the time, I did not have a reduction of that pain on biting. It continued, which was very frustrating. But then in dental school and other clinicians that I talked to, if they had a tooth that never settled down, it was always the crown was on, pain on biting was still there. The next step was root canal treatment. Okay, well, it costs some time, costs some money. Patient's not happy about that. I'm not really happy about that, but I get to be really good at doing root canals. I was trained by some of the best undergraduate faculty members in the world, Steve Cohen and Alan Gluskin. They wrote the book Pathways to the Pulp. Our class valedictorian became a world lecturer in endodontist, Steve Buchanan. Anyway, we had a lot of training in endo, so that was just something you just shrug your shoulders and do the root canal. But then 10 years later, a number of these teeth failed catastrophically. I can remember one patient specifically. She came in with the crown in her hand. In the crown, she had the buildup and the tooth structure that was holding the buildup to the roots, which had now been detached. And I looked at that and I said, Cindy, wow, you must have eaten something really hard. And that's how much I understood about a fractured tooth. I didn't understand crack initiation, crack propagation, but the main thing I didn't understand is that I had not diagnosed that this tooth had a fracture before I crowned it to treat her cracked tooth syndrome. The endodontic treatment took away her pain that had continued after the placement of the crown. And then when she came in and it was fractured subgingivally, this tooth could not be saved at that time with any techniques that I had, so it was lost. Now, she's since passed away 4 years ago. I talked to her husband. Well, I'm trying to just put things into perspective because my job as a dentist is to give options to a patient, and sometimes the option for a patient is, I don't want to deal with that problem, let's just take the tooth out, which can be a real blessing because a dead tooth can abscess and cause some more systemic problems. But the idea is that me personally, I hated that Cindy had lost her second molar after I had treated it with a crown, treated it with a root canal, and then 10 years later, the tooth was lost. Now, for most dentists who are more progressive than I am, by the time I had that catastrophic failure, most dentists would have said, well, if you would have started to get trained on implants earlier, like I did, then you could have given her the next option, which is an implant. I mean, I'm trying to not be sarcastic. I'm trying not to be bitter. I'm trying not to be jealous. I'm a human being. In my brain, I am looking for either a new profession, which was going to be history. I'm enrolled in graduate programs. I've taken the graduate record exam. I've been accepted. And we're going forward to become a historian, a history professor, and take a minor cut in pay that my wife wasn't going to complain about too much, I think. I don't know. We never did that. But the idea is that quitting dentistry was more desirable to me at that time because I had an inconsistent results on treating cracked tooth syndrome. Because I was introduced to adhesive dentistry, the idea of adhesive dentistry actually reconnecting a tooth was very attractive. And the advances in adhesive dentistry through better adhesive products and then better techniques still led most dentists down the path of saying, okay, we're just going to glue that together. And all of a sudden, that cracked tooth syndrome will go away. And in my experience, it did go away for 4 years. And then at 4 years, some of the teeth that I adhesively bonded together started to have the same symptoms of cracked tooth syndrome. And again, do I do the endo? Well, yeah, I want to save the tooth. We do the endo. But then at about that time, this would be 1999, I was introduced to microscopes by Steve Buchanan. I went to a 2-day course in university at Ohio State, the Ohio State University Dental School. There were 100 dentists there getting advanced endodontic training. Steve Buchanan was the teacher, and he had 10 endodontists assisting him, and we each had the opportunity to use microscopes, most of us for the first time. Once I saw what a microscope was going to give me as far as what I was doing in adhesive dentistry, I was sold. And so I went home. I'm ashamed to say it, but I had $10,000 in the bank. I'm not ashamed that we had $10,000 in the bank, but I'm ashamed to say that I spent the $10,000 on a microscope without asking my wife. So there's a saying that it's easier to get forgiveness than permission sometimes. And she agrees. Without a microscope, I would not have been able to stay in dentistry because I still did not have the confidence that this new adhesive dentistry was going to change the profession from the traditional frustrations. But 1999, 2000, January, I got my microscope, and all of a sudden, caries, which had been my main focus from 1995 to 1999, now my main focus became cracks from 1999 to 2003 when I first started teaching 6 lessons, because now I had that missing link, the missing key to having 100% success, because I could see the cracks, and my knowledge of engineering, which was basic, but still I had friends who were engineers. I just asked them, you guys are professional engineers. What if you have a crack? What do you do with it? And they were taught in engineering school to dissect cracks, take cracks out. If they were working on a bridge and it had a crack, they would take the crack out. Bridges are made by a lot of connections in those days that were metal to metal. And so they would have the rivets, and these rivets that were connecting pieces of sheet metal, many rivets, under micro movements. The car's moving, there's little micro movements start shaking the molecules in the metal, and pretty soon we get some cracks around the rivets. And in certain situations, those bridges failed catastrophically. The bridges collapsed. And then all of a sudden, the engineers looking at this catastrophic failure, they were the first ones to notice that these rivets, some of them had small cracks around, and these cracks had grown, and eventually the crack had propagated through the whole bridge and caused a catastrophic failure. So what was their approach to prevent future catastrophic bridge collapse? Early diagnosis. They went and looked at every rivet on every bridge, and guess what? There were some cracks. And what did they do? They took a big drill and drilled out the whole rivet with its crack. So now they have a big round hole, and then they put a big bolt and they screw it on. That was the mechanical stabilization of this potential catastrophic failures in bridges. The same thing happened with airplanes. Airplane wings made of metal, airplane wings made of plastic, airplane wings made out of wood. Actually, wood was the least prone to cracks. Why? Because wood was not a brittle material. It had a nature that is called tough. Wood is a tough material. It's not brittle. And the difference between toughness and brittleness in plastics is just a function of how the plastics are made. If they have fiber in them, another of our lectures will be on that. But this information that I learned from my friends who were engineers was a real eye-opener. And so I started reading books engineering books on fractures, on cracks and diagnosis. And blunting a crack at the tip was the best way to make sure that that crack would never cause a catastrophic failure. So in 2000, I dissected my first crack using my $10,000 microscope. And when I did, I had enough knowledge of adhesive dentistry to know that now I had created a high C-factor situation. In other words, the ratio of bonded to unbonded surfaces on a trench, on a dissected crack, the ratio of bonded to unbonded surfaces was so high that the C-factor stresses, if you restored that with 2 increments, a 4 millimeter crack dissection, if you did 2 increments, then you would have a debond on one wall of that restoration. So at that point, we had resin coating as an understandable application of reducing C-factor for the first 90 seconds of a restoration. And of course, I was the only person in the world that was thinking in those terms. How did I know that? I'd talked to everybody for 5 years that knew anything about adhesive dentistry. Gary Unterbrink was the only one that had the idea of polymerization dynamics. And on his direct restorations, he was always putting a layer of flowable composite. And when he talked in the terms of flow, the next year after I had met him face to face in 1998, he wrote an article with Naren Wilson called Decoupling Approach to Reduce Sensitivity on Large Composites. It's not the exact title, but in 2000 in Quintessence International, Gary Unterbrink and Naren Wilson published that paper, and that led me to create the decoupling with time that I'm famous for. Infamous? I hope not. I mean, it's just like science. Why would anybody not understand decoupling with time? You just have to ask them. And then if they haven't talked to me, good luck, because, we've got 2,000 articles here that say time is the missing element of all of your adhesive failures. Well, that time is related to how long you delay the connection of the size of your preparation. And the way you delay that is by making them very thin initially or placing fiber that can allow composites to move in 2 directions. And that science came in 2002. So in 2002, Semabelli was publishing fiber posts. In 2008, Erkut published the scanning electron microscopy that showed the exact movement of the polymers as they were entangled within the ribond. And all of a sudden, we had 2 ways to decrease C-factor with time and with fiber placement and small volume increments. Those 3 foundational principles allowed us to prevent a root canal failure because losing a bond, or a very narrow high C-factor preparation that looked kind of like the shape of a root canal being restored in a crack dissection. And so the systematic approach that we developed was based on polymerization dynamics. I learned from Gary Unterbrink, bulk reduction by Nikolenko 2004, and then in 2006, 7, and 8, the fiber placement that Semabelli, Erkut, and El Moafe published. There's a system that if you do that, then you can have the same results, but you have to dissect the crack. Otherwise, the crack will continue to propagate. And we will talk about that next time. Until next time, stay bonded.